esteemed members of the Pharmaceutical Society of Kenya, esteemed members of the various professional bodies, healthcare bodies in this country, Kenya Medical Association, Kenya Pharmaceutical Association, Kenya Clinical Officers Association, the National Association of Nurses in Kenya. Welcome to today's webinar. Today's webinar is today's course management webinar being done and being hosted by Pharmaceutical Society of Kenya in collaboration with KMA and all other healthcare bodies. Welcome to today's meeting. We're going to begin in the next 3 minutes. By the time either we get to 100 attendees or by 2:05. The sooner we get to 100, the sooner we begin. The sooner we get to 100, the sooner we begin. Karibuni sana. Please let me know which association in the chat box, which association you're coming from. Just on the chat box, you can just write my name. I can see Dr. Alex Ugeti, a community pharmacist based at Feather. You just write your name, place of work, and probably the profession of which you're joining us from. Karibuni sana. Once again, welcome all. I can see this Dr. Anthony Kodiro, pharmacist from Nairobi. Dr. Dirango Mugo from Nairobi County, Asante Sana. Dr. Agoral, Karen Chemist. Dr. John Kadesa, pharmacist from Kakamega. Thank you very much, Dr. Farida Chakera, a pharmacist and an official of the PSK Coast Branch. Karibu Sana for joining us this wonderful afternoon. Dr. Solomon Muturi from Loyola Pharmaceuticals Limited. Karibu Sana. Once again, let me I do wish to welcome you all in this webinar and this COVID-19 case management webinar. It is on evidence-based practice. This webinar today is hosted by Pharmaceutical Society of Kenya, Kenya Medical Association, and all other healthcare associations, including the Kenya Medical and Pharmacist and Dentist Union. Just a little bit, allow me to welcome the Vice President KMA to give his opening remarks just before we begin. And I had promised you we'll begin either the closer we get to 100 or at 2:05. So now, if I allow Dr. Amos, are you with us?
Oh, yes, thank you so much.
Karibu sana, give your opening remarks, Dr.
And on behalf of Kenya Medical Association, I really want to welcome you all to this webinar. KMA, in partnership with the other medical associations and pharmaceutical, nursing, and all this, are committed to ensuring that we get quality presentations. And today we are privileged to have a presentation on randomized controlled trials because we trust in evidence-based practices. So I hope you will enjoy our presentation, and karibu sana. Thank you.
Asante, Daktari. Thank you very much for joining us. I also want to recognize the presence of a senior health systems specialist. That is none other than Dr. Norbert Rakiro. Karibu sana, Daktari, for joining us this wonderful afternoon. As I had promised, esteemed members of the various professional bodies, seniors and respected members of the healthcare professionals, welcome to today's webinar. It's on a COVID-19 case management. It's a COVID-19 case management webinar. Having the mental health webinars on Tuesday from 7 p.m. We now have our COVID-19 case management webinar. Just a few rules for us to as we get into this webinar. First, we all remain muted. Apart from that, this webinar is currently live on Facebook and shall be live on our YouTube page. Our CPD points will be issued for the pharmacists and the pharmaceutical technologists. Those are members who are regulated by the Pharmacy and Poisons Board. The CPD points will be issued. Yes, it may not be on the board at the moment. By today evening, it shall be on the Pharmacy and Poisons Board. So that we're going to work on. And other than that, I also do wish to welcome the senior respected member, Dr. Winston Makanga, Nakuru. Karibu sana, Daktari. Ladies and gentlemen, without further much ado, let me go to what that has brought us here today. And today's topic is none other than is on evidence-based practice. It is on critical appraisal of randomized control studies. It is by a great and young pharmacist. Her name is Dr. Ann Massey. Dr. Ann Massey practices at the Kenyatta University Teaching, Research and Referral Hospital, KUTRRH. And ladies and gentlemen, without further much ado, it is now 2:05. Dr. Ann Massey, are you with us?
Yes, Mbao, I am.
I allow you to share your screen now, Dr. Our esteemed members, kindly post your questions and on the Q&A tab or any other comment you have on the chat box. We'll be able to handle it from there. Ladies and gentlemen, let me now introduce Dr. Ann Massey Wanjiko. Dr. Take it over.
I would like to believe that you can see my screen.
Wonderfully well, I can see your screen and I can hear your voice loud and clear.
All right, thank you so much, Mbao. As you've rightfully said, my name is Dr. Ann Massey. I'm a pharmacist working at Kenyatta University, Teaching, Referral and Research Hospital. I'll be taking you through a critical appraisal of one of a randomized clinical trial of a novel antiviral that is being set to be used for COVID-19 management. So I would like first to appreciate the presence of everyone who's been able to join in. I know this topic is broad, so we might not cover everything, but I hope that at the end of the session, it will be enough to pique your interest so that you're able to follow through in learning the scientific way of appraising trials for you to know whether they should affect your practice or not. I also appreciate the presence of senior professionals. I look forward to much later when they can, give us their input, as well as teachers, because I believe the more you practice, the more you get to understand and get the ability to really capture the basics and the nitty-gritties of our practice. So thank you. We'll start with a slight definition that critical appraisal is definitely a process in evidence-based medicine. It assesses research and determines if it could have a clinically significant impact on their patients. So a critical appraisal allows you to know whether this particular research, has it been conducted in the prescribed ways, and then the results that have been gotten, are they enough or are they statistically significant enough to allow me as a clinician or a practitioner to change my practice? So critical appraisal allows doctors to exclude research that is too poorly designed to inform medical practice. So the main reason of critical appraising is the fact that we can't just take research at face value. There are so many research, some even on the same topic, that give conflicting conclusions. So it's up to us to critique a paper for us to identify whether this is information that we can actually act upon. So we have several tools that guide us when we are doing a critical appraisal. We have Consort 2010 guidelines, or CASP, Critical Appraisal Skills Program, RCT checklist. So these are a few of the ones you can actually look up. This particular presentation will rely heavily on the Consort 2010 guidelines. So when we look at a paper at face value, what do we see? We see a title and an abstract. So for us to have our interest piqued, the first thing we look at is the title. Is it catchy? Does it grab our attention? Does it tell us at face value that this is the paper that you're looking to read if you're looking at a particular topic? So according to Consort, the title must be catchy. It also must contain the term randomized clinical trial as part of its title. So today we will, as we try to understand how to critique a paper, we will use this particular study. It's called, the title is Molnupiravir for oral treatment of COVID-19 in non-hospitalized patients. So this is a clinical trial that is ongoing that was assessing the efficacy and safety of the drug, the antiviral drug Molnupiravir in the treatment of COVID-19 patients. So recently, earlier this month, I saw WHO approved it for use. So this is something we'd like to see as clinicians. This new drug that's been introduced, is it something that we can actually apply in our practice? Should we just follow blindly because up there they've agreed that it is working, or should we critique it and ask, does it apply to our population? So when it comes to the title, is it catchy? Our title is Molnupiravir for oral treatment of COVID-19 in unhospitalized patients. It's quickly telling us that we are dealing with a drug that is being used for the treatment of COVID-19. The fact that it is short and precise means that it can grab your attention because it doesn't bog you down with a lot of information. But according to Consort, did it indicate randomized clinical trial? I do not see that. So depending on each guidelines, they will direct you on how or what is expected in every section of the paper. So moving on to the abstract, I know it looks busy, we won't read much of it, but the abstract is normally a structured summary of the trial design, methods, results, and conclusion. So this is what? It's a snap view of the entire paper. So it tells you the background. Why are we doing this? What is it about? Which methods did we use? What were the results we got? And what are the conclusions we made following the results we got? So it's a snap view of the entire study. So in our abstract, you can see it included background, it has methods, results, and the conclusions. So we can say that for abstract, it actually has what is required for us to say that the abstract is complete. The next section in our paper is the introduction. So here in the introduction, the key things that are addressed is the basic science justification and the clinical justification. So under basic science justification, this is just the scientific background. So in our paper, we are dealing with a drug. So we expect under basic science justification, it tells us how the drug actually works. So in our case, our drug is Molnupiravir, which is an antiviral. It is its mechanism of action, in short, is that it interferes with RNA replication, therefore rendering the virus non-infectious and unable to replicate. So that's the scientific background towards it. But now what's the rationale of actually doing this study? So the rationale in this instance will be that we do, of course, we're experiencing COVID at the moment. We know that vaccines lower the need of hospitalization, but we also understand that the coverage, all this I'm getting from the introduction, which I couldn't put here, but we know that vaccines, the coverage of vaccines is not sufficient, and especially in Africa, but also the entire world. The vaccination rates are not as high as we'd like them to be. So now the rationale of this paper is to see, do we have an oral antiviral therapy that can reduce the risk of disease progression and eliminate the need for hospitalization? Another rationale in this instance will be, this is a phase 3 trial. So this trial called Move Out has actually gone through phase 1, phase 2. Now these are interim results of phase 3. So still another clinical justification that we now need to move to phase 3, where we will look at a larger sample size, as well and now look more keenly at effectiveness in addition to safety. So that's it about introduction. Our next step is usually materials and method. So the key thing here is the study design and setting, or that's what we'll start with, study design and setting. Remember, we said for a paper, for us to deem the results significant, or for us to deem the results applicable, the study design must be robust enough to ensure that the results we get are accurate or very close to the truth. So the study design in this particular paper is a randomized control study. So an RCT is the gold standard when you're studying treatment effects. This will involve allocation or assignment of participants in a random manner with the aim of minimizing selection bias. Also, an advantage of randomizing is that it might equally distribute the confounding factors, which we'll look at later. And finally, it's a reliable measure of efficacy. It's one of those on the pyramid of evidence, on the strength of evidence, it's pretty up high there. So our study is a phase 3 double-blind parallel group randomized placebo-controlled trial. So that's the study design, that it is in phase 3, as we said. It involves a larger sample size. It's double-blind, which means that both the researcher and the participant are not aware of which treatment arm they're in. It's parallel, which means that the arms or the groups will receive different interventions, and these interventions are run independently of each other at the same time. And it's also placebo controlled. So we have the drug or the treatment arm and the placebo arm. So the question in this under study design we need to ask ourselves is this design appropriate for the study or for the main aim of that study, which we've identified that it's the gold standard when you're studying treatment effects. Under setting, this study has been done in 20 countries involving 107 sites. This just goes to show that they've really tried to spread out and get as much subgroups of participants as possible. So we'll now look at Pico. Pico is an acronym for population or patient, intervention, comparator, and outcome. Pico specifically helps us to design the research question. It helps us to format a good research question that will articulately express what we are trying to do. So for our trial, for our study, the one that we're looking at, so for population, we're looking at the patient, the characteristics of the patient. So in our case, the population was unvaccinated and hospitalized patients who have not exceeded symptoms past 5 days. So all that I've said will be included in the inclusion and exclusion criteria. In most instances, the patient must meet all the inclusion criteria for them to be included in the study. For them to be excluded, they must meet at least one of the exclusion criteria. When we come to the intervention, in this particular study, we are using 800 mg of molnupiravir given twice a day for 5 days. So the intervention is what you're trying to, is it the new drug that you're trying to show? Or is it when you're trying to compare two drugs and you want to say this might be more efficacious than this other one, the intervention is what you're trying to show that it's more efficacious than the other. The comparator now in this case is the placebo. So under outcome, we have two outcomes, or normally have two outcomes. We have the primary outcome and the secondary outcome. So the primary outcome is the one that directly addresses the research question. So it can be 1 or 2, but that is that is what has informed the study design. The study has been designed specifically to come up with a primary outcome. So in our case, the primary outcome was hospitalization and mortality. That's the outcome we're looking at. When it comes to secondary outcome or ancillary outcomes, these are outcomes that come about in the process of coming up with the primary outcome. However, they are not the main focus of the study. So when we look at our research question, does early treatment with molnupiravir reduce the risk of hospitalization or death in at-risk unvaccinated adults with COVID-19? So let's critique it. Does it meet the Pico format? Does it have the patient? It clearly tells us it's at-risk unvaccinated adults. The intervention in this case is molnupiravir. The comparator is a placebo, and the outcome is hospitalization or death. So in this instance, the research question has been informed by Pico, or rather it has the format of Pico, which now helps us to really focus our study on one particular thing. Now we come to sample size calculation. Under sample size calculation, this is a very key stage during the formulation of a study. Reason being, a very small sample might give you, will not give you a very strong confidence in the results. Allow me to say that. So if you are able to tailor your sample size to, according to, now we'll look at these parameters, it will ensure that the sample size is robust enough to give you confidence in the results we get. It will ensure our estimates are precise, and therefore our study will be, there'll be power to our study. We'll be confident to say that, yes, the results in this study are things we can bank on. So when you're calculating size, sample size calculation, there are three parameters that should guide you. The first one is alpha. The alpha is a statistical significance of the observed difference. So this basically is telling us that the difference observed between the intervention and the comparator is statistically significant. So a p-value now comes in to indicate, so the alpha is set as 0.05 for a one-tailed test, and for a two-tailed test, it's set as at 0.025. So now for the p-value now comes in to say that the chance of this, rather, there is the chance of this result, or rather the probability of this result happening due to chance is less than 0.05. When it is less than 0.05, then we are sure that we have a significant, or rather the result has statistical significance. So the less the p-value, the less the probability that that outcome is due to chance and not the intervention. So here, our test was a one-tailed test. We were looking at its efficacy. So it could only go one direction, efficacy. So it's a one-tailed test, and we use the p-value of 0.05. When we look at the power, this is the probability of finding a true difference. In this instance, it's recommended that the power should not be less than 80. So our study actually used 95% power. This was to ensure that if we say that the intervention had impact, had true effect, then we are 95, the study has 95% power to indicate that actually the difference we are seeing is very close to the truth, or rather it is true. Then the third parameter you use when you're calculating sample size is the clinically meaningful difference. So this is a difference that supports change. So if it has met this clinically meaningful difference, then you're confident in changing your practice. So if you've been using drug A and another drug B has come in and it has a clinically meaningful difference that has met the criteria that had been set, then it will support your decision to change from drug A to drug B. So normally the clinically meaningful difference is determined in 3 ways. One, from prior studies or from prior data. So previous studies that may have done and come up with this clinically meaningful difference will inform on the difference that you'll use on your study, or a pilot study. You first do a pilot study before going to the main study. Another that way of coming up with a clinically meaningful difference is calculation, a personal calculate, you calculate the value personally. However, when you calculate, it's not very convincing, or it doesn't render power to the difference you come up with. When you use prior studies or data, then that is a very strong, clinically meaningful difference. Our study had a clinically meaningful difference of 6% in the intervention arm. That is the patient who are receiving molnupiravir. While in the placebo arm, their clinically meaningful difference was 12%. So that means that if within the intervention arm there was a change of 6%, then that difference, or rather the results would allow, or rather that difference will support us in changing our practice. So once you've now come up with a sample size and you've collected data, then further analysis needs to be done. So what are the basics of this further analysis? The key thing is to first identify what data have you gotten, or what data are you intending to get. So if we have normally distributed data, which from the figure you can see it's in the shape of a bell curve. So for normally distributed data, you'll see that the mean, the median, and the mode align. Whereas non-normal data, this is data that is skewed either positively or negatively. And in this instance, the mode, the median, and the mean do not align. Whereas categorical data is reported in groups. So we can compare it as gender, male, female, or age. So we say from age groups of, say, 21 to 30, 31 to 40 years. So those are the 3 data you may have: categorical, normal, or non-normal. So now when you're giving your results, you will analyze your results or that data. So if you're having categorical data, then you'll use the mode or the frequency. If you're using normal data, say you want to tell us more about the age, then you'll give us the mean age of that group, if that is normal data. So you either use the mean or the standard deviation when giving us the results. For non-normal data, then you use the median or the interquartile range. So this you'll best see it in a table 1, which we'll look at in the next slide. So you'll best see it in a table 1, because now when they give their results, if it was age, if it was sex, then if it's you will infer the type of data they had by looking at the measure of central tendency they use. So if they used mode, you'll know this is categorical data. If they used mean, then that means it's a normal data. If it's median or interquartile range, then you know that's a non-normal data. Still looking at further analysis of basics. So once you've identified your data, you have been able to present the results using the measures of central tendencies we've talked about. Now, further analysis means now you need to interpret what your data is telling you. So these are, you'll forgive if it's not so clear, that table, but this gives us a summary of the statistical tests that you'll now use to compare the samples. So once you've identified that you have a categorical data, and it is the studies of one sample compared with a hypothetical sample, then those are the statistical tests you may use: the chi-squared test, the Fisher's exact test. If it's non-normal data and it's one sample compared with a hypothetical sample, then you use the sign test or the Wilcoxon signed rank test. And say if it's normal data and it's one sample, then use the one sample t-test. And the rest follows. So some of the software we use, like SPSS, they have this statistical test inbuilt. But it's good in case you ever see this under the tables, you're able to understand why we are using them and for what data. So it also assists you to know, did they use the right test? Because we are still critiquing. So have they used the right test? So once you categorize your data, then you will know that yes, they've been using, or rather that the right test has been used to interpret the results we've gotten. So we can now go to the tables. So the table 1 is the one that usually has the baseline characteristics. That's the demographic and clinical characteristics. So you can see from our table 1, this is still the study we're talking about, the molnupiravir versus placebo study. So looking at this table, it's giving us the results without much analysis or delving into what the data is telling us. We haven't gotten to the point of what is the data informing us. It's just telling us this is what we got. So we'll look at a few. We can see that for the female sex, we had 384 females in the arm of molnupiravir. Please note we have two arms, molnupiravir and the placebo. That's the intervention and the placebo. So for the intervention, they were able to randomize 716 patients. For the placebo, they were able to randomize 717 patients. So under the intervention arm, out of the 716 patients, the female sex was 384, which accounted for 53% of the people in that group. For the placebo, the female sex had 351. We had 351 females out of 717, which now accounted for 49%. And the age group, you can clearly see for people above or equal to 50 years, it's at the intervention arm is at 32.4%, and placebo is at 35.1%. You can also keep looking the risk factors as well. They looked at least one risk factor, either obesity, age above 60, diabetes mellitus, and the like. The COVID-19 severity, was it mild, moderate, or severe? The variant of the infection, the variant that infected our patients. So when we look at table 1, in as much as we are seeing this data, what are we looking at, or what do we want to see? We want to compare the both arms so that we see if there was a selection bias. In this instance, we can see, we can actually see that for females, they are close to one another. It's 53 and 49%. We have a median age range of 18 to 90 and 18 to 88. Also looks similar for, say, one risk factor like obesity. Okay, at least one risk factor is at 99.4 and 99.3. So we can say that almost all the patients in either of the arms had at least one risk factor. When we look at COVID-19 severity, we see mild at 55 in the intervention arm, 55.2 in the intervention arm, and 54.4 in the placebo arm. For moderate, 44% in the intervention arm and 45% in the placebo, they look quite similar. However, the danger in comparing at face value just by looking at them is that you might not know whether this difference is statistically significant or not. Does it have any impact? So, for example, say which one has a wide range? We can look at the age above 60. We have 16.6% and versus 17.7% in the placebo arm. It will be hard to tell whether this has significance, or rather this difference has a direct impact to our results or to the conclusion without using a p-value. Now, the challenge with p-value is that some guidelines say you need to put a p-value in table 1. We have the basic characteristics, others say not. But in my opinion, I feel a p-value would help us know whether the difference we are seeing, is it statistically significant to the outcome? So basically that's it about table 1. You're supposed to just compare, see, is there any selection bias? Because if there's selection bias, and this comes in especially when blinding is not present, then the researcher might decide to put the mild patients in the intervention arm and probably less of the mild patients in the placebo arm. And this now may, the selection bias might actually not be deliberate, but it may be influenced when there is no blinding. So when you look at the demographics table, you're actually looking at, is there much difference between the two arms, looking at the characteristics given. We will now go to the next table. So the next table is analyzing our data further. The table is just giving us an overview of what they got. But now this table will start analyzing exactly what we got and what it might mean to the outcome of the study. Remember, our outcome was the incidence, down there you can read the incidence of hospitalization or death. That's the outcome. We're looking at hospitalization or mortality. So now this table will try and break down the info we've gotten for us to see, is the result statistically significant to our outcome? So under this, in this table, we see a subgroup. So the data has actually been further subdivided to now subdivided in terms of trying to interpret what each means. So it has been put in groups. So one subgroup is the sex. So here we are trying to look between female and males. How was the incidence of hospitalization or death at day 29? So what the number of events here means, the number of incidences of hospitalization or death. So the females under the molnupiravir arm, or the treatment arm, had 16, or rather there were 16 events out of the 379 participants, while the placebo had 27 incidences of either hospitalization or death out of 344 participants. So just, and then the male under the intervention arm, we had 32 events or incidences of hospitalization or death over 330 participants. Whereas under the placebo, we had 41 incidences of hospitalization or death out of 355 participants. Now, looking at that at face value, we might then infer and say that molnupiravir seems that it is more effective than placebo. However, as I cautioned earlier, just looking at this data, the way it's presented, will not tell you whether that difference is significant or not. Is that a difference that will change your practice or not? So now that's where it's further analyzed, and now you can look towards the end. They're using the confidence interval parameter here. So they've set their confidence interval to 95%. Most studies are recommended to use 95% of confidence interval. So a confidence interval basically is telling us, for our instance, 95% confidence interval, it's telling us that we are 95% confident that the result we are getting from this sample will be replicated in the population. Or let me rephrase it. We are the true value of the outcome we're looking at will be present or will be contained 95 out of 100 times. So that's the confidence interval, or rather how I look at the confidence interval. So looking at the numbers at the final end, at the farthest end to the right, we see into brackets that our 95% confidence interval is giving us between -7.4 to -0.2. And I know this is a lot of mathematics, but please bear with me. Let's try and move slowly and together. So looking at that range, -7.4 to -0.2, that is telling us, or rather that has fallen within the 95% confidence level. So our proportion for females is at -3.6. So it has actually fallen within the confidence interval. When we look at the males, we see the 95% confidence interval is at -6.5 to 2.8. The result we got is at -1.9, which then we can say that it actually falls within -6.5 to 2.8, or rather it falls within our 95% confidence interval. However, in as much as it has fallen within our confidence interval, we need to ask ourselves, is this risk reduction, where now the risk reduction is the effect of the outcome? So in our case, we're talking about hospitalization or death. So is the reduction of hospitalization, or rather is the difference between the two arms, the difference between intervention arm and the difference between intervention arm and the placebo, that difference in the incidences of hospitalization or death, does it actually, is it actually statistically significant? So first, we've established that both the female and the male results fall within our 95% confidence interval. So now, using the absolute risk reduction, we want to find out, does this result, is it significantly statistic? Is the difference between the two bad outcomes, that's hospitalization and death, between the two arms, out of the bad outcomes, that difference, because we can see the difference here being 16 and 27 and under the female. So we have 16 bad events under molnupiravir and 27 in the placebo arm. That difference, is it statistically significant? So now that's when we use this forest plot. So you can see the range that has been indicated there. The line that cuts across that ends at 0, that means that the difference, or rather, there is no effect, if I may say so. There is no effect between using either molnupiravir or placebo. So, or rather, the impact is 0. There is no, yeah, exactly. There is no effect between the two. So if something, if a range falls within 0 where there is no impact, then we can say that that result or that intervention is not statistically significant. So I'll say that again. So we've identified the difference between the two bad outcomes, and we say the bad outcomes is hospitalization or death. So under female, we've identified that it is 16 and 27. Once we look at the confidence interval, that difference is true. It has fallen in our 95% confidence interval. But is that difference statistically significant? Is it something that we really should take up? So now we use the forest plot. At 0, we know that there is no effect. So if that range cuts across the 0 line where there is no effect, or rather, the difference, there is no difference. There is, 0 means that there is no impact of the intervention arm. So if it cuts across that, then it shows that it is not statistically significant. So for the female, you see the range, which was between -7.4 to -0.2. It actually falls to the left side of the 0 line to indicate that the differences observed in the outcomes is statistically significant in the female population. When we look at the male population, once we get the difference of 32 in the intervention arm and 41 in the placebo arm, it falls within our range of -6.5 to 2.8. However, is it statistically significant? So you can see the range has fallen, or rather has captured the 0 where there is no impact or no effect. So then that means that the difference we've observed is not statistically significant. So we'll look at the ones that have actually, that show that molnupiravir is better, and it is better statistically significantly, that the effect is statistically significantly. So we'll look at days since onset of symptoms. So we can see for patients whose onset of symptoms was, by the time they were starting their treatment, was more than 3 days, the difference was -4.8, which fell between the range of -9.0 to -0.7. That meant it didn't cross the 0 line, which then means that the difference was statistically significant. Then it means the effect of molnupiravir in patients whose onset of symptoms before the intervention was more than 3 days was significant. We can also look at another example, obese, one of the risk factors, obese patients. So the difference was -3.7, which clearly falls between -6.9 and -0.5. That range hasn't fallen on the 0 or where the no impact line. Therefore, in obese patients, the effect of molnupiravir was statistically significant compared to the placebo. And you can go down and interpret all that. So once you're done with the analysis, the results and the analysis, you now go to the discussion. So for us, when we are critiquing a paper, the question we need to ask ourselves is, did the results, or does the results and the conclusion marry, or are they on the same page? So the second statement there, hospitalization or death through day 29. So this is an average of all the subgroups that we've seen. That one was just to help us see how they interpret per each subgroup. So for the entire study, these were their results. The hospitalization or death was for the intervention arm. That is for the patients who received molnupiravir. So for the intervention arm, the incidences of hospitalization or death were 7.3%. So out of 100, 7.3 of them would have been hospitalized, or they would have died for the patients who are receiving the antiviral drug. But for the ones receiving placebo, then the hospitalization or death incidences were at 14.1%. So looking at that, it looks like, yes, the molnupiravir actually had effect because we had less incidences of hospitalization or death. But as I said, we have to use statistics for us to know whether it's statistically significant. So in this case, when you subtract the difference, when you get the difference between the two arms, the molnupiravir or the intervention arm and the placebo arm, it's coming to around 6.8%. So 6.8 negative 6, when you take 7.3 minus 14.1%, it's coming to negative 6.8%, which is the same as negative 6.8, which, as you can see, it falls within our confidence interval. Remember, we are working with a confidence interval of 95% that we established when we were calculating sample size, or rather when the protocol of this study was being done. So our negative 6.8 actually falls within the negative 11.3 to negative 2.4. Remember, we said at 0, then it means there is no impact. So if the interval crosses 0, then that means the results we've gotten, or rather the difference between the two arms, intervention or the placebo, the difference is not statistically significant. So in our case, we can see it has not crossed negative 0. So we can confidently say that that the molnupiravir or the intervention molnupiravir had statistical significance, or rather the effect on hospitalization or death was statistically significant. Another way of interpreting results is using the p-value. So our study really focused more on the confidence interval, but both of them, confidence interval and the p-value, will help you in interpreting, or rather deciding whether a study is or rather the results of a study are statistically significant. So our study worked with a p-value of negative 0.05. The p-value obtained from these results was negative 0.00. Sorry, the p-value was 0.05. There's no negative, was 0.05. The one that was set, that was what we set our p-value to be. So anything else beyond that then would mean that we have that the results we are getting are due to chance and not the intervention. However, if the p-value is less than 0.05, then it means less and less, or rather, we've reduced the probability of the outcome being due to chance and not the intervention. So in this case, our study, the results got 0.001, which is less than 0.05, which then we can infer and say, so a p-value negates the null hypothesis. So if we were to formulate a null hypothesis for a study, we will say that there is no difference in the hospitalization or death between using the intervention arm, molnupiravir, or the placebo. So there is no difference whether you use the molnupiravir or the placebo. That's the null hypothesis. So when the p-value is less than 0.05, then that means we reject the null hypothesis. So in this instance, we are rejecting the null hypothesis and saying that there is actual a difference, or rather, there is a difference between the two arms, the molnupiravir and the placebo arm. So the conclusion, and this statement is gotten from the last part of that study. So the statement says that in this trial, oral molnupiravir was found to be effective for the treatment of COVID-19 without evident safety concerns when initiated within 5 days after the onset of signs or symptoms in this population of non-hospitalized and vaccinated adults who are at risk for progression to severe diseases. So yes, we can see that as per the results after analysis, we can actually agree with the conclusion that molnupiravir was found to be effective for the treatment of COVID-19. So that's how you critique a paper. And finally, you need to ask yourself, does the results match the conclusion? because once they do, you've established that the study design is robust, so the results you're getting are accurate and are geared towards your primary outcome. Then it's at that point then that you decide that the results of this study will influence my clinical practice. So just before we end, we also need to look at something called validity. So under validity, we have two validities. So validity just means it's the degree to which the test is capable of measuring what it is intended to measure. So this study was intended to measure whether molnupiravir lowers or decreases hospitalization or death in COVID-19 patients. So is our study valid in terms of did the results, was the test capable of measuring? Did the design align to, was the design accurate? Was the setting accurate? Was the interpretation of the data accurate? For us to believe that now the results we get are true, because that is what renders the study capable of measuring the outcome. So we have two validities, the internal and external. So for internal, it's the degree to which the results observed are correct for that particular group, the group under study. So here you look at the study design and how the study was executed for us now to say that the conclusion is robust. The conclusion has power. That's internal validity. When we come to external validity, here we just mean that can we generalize the results to groups outside the study or to populations outside the study. So in we cannot have, a study cannot have external validity before it gets internal validity. So it must first have internal validity. And we've said there, you look at the study design and the execution. The execution now means in how they blinded, how they contracted, or rather how they got their participants, how the treatment was given, how the data was collected, how it was interpreted. All that tells you whether a study is valid or it has internal validity or whether the results observed are true. After which we now look at external validity, where we generalize, we ask ourselves, this was done in, I don't know, let's say in America. Can we generalize those results and say that the effect seen in America will be similar to the effect we'll see in our population? So some of the things that increase external validity is, one, when you use a diverse population, or it has multiple sites, because now you're enlarging your coverage of the populations. So we'll just discuss this. They came up from the study. I'm hoping we can all get to read it later. So this actually came up from the study. We have intention to treat. So when we talk of intention to treat, we are talking about, it's a form of analysis, intention to treat analysis. So we are analyzing participants, or rather the results gotten from participants who are randomized. So now the analysis looks at the results of the group as they were originally assigned. So if we had 341 people randomized to fall under the intervention arm. So regardless of whether they completed the treatment, they got lost to follow up, or something changed within their treatment, we will analyze that data originally using the 341, the way we assigned them. Whatever happens in between, we will not look at it. We'll just look at the point of assigning. We had 341 people in the intervention arm. That's the number we will work with. That's intention to treat analysis. Then, of course, randomization. This we just assign randomly, and we said the purpose was to ensure there's no selection bias. So our study, so for randomization, there are several ways you can do it. It can be automated. you have to decide in your protocol how you want to randomize it. So for this particular study, the randomization was using a technology system. Blinding, so we also talked about blinding. We can have single blind, double blind, triple blind. So for the single blind, the patient doesn't know which treatment arm they fall into. For double blind, both the researcher and the patient do not know which intervention arm they've been assigned. While triple blind, it's the researcher, the patient, and the analyst. They do not know who has been assigned what treatment arm, or rather, who has been assigned which arm. Is it the treatment or is it the placebo? And then for interim analysis, once you read, you realize that our study, these results are from an interim analysis. So an interim analysis is where before we complete what is it called? Before we complete our study, or rather recruiting, before we complete recruiting our participants. So we've already set our sample size to say 1,000. So before we reach the 1,000 mark, we can conduct an interim analysis, which now will inform whether we need to modify our study. So when an interim analysis is done, we can either have termination. So if in case we are getting very many deaths, especially in the placebo arm, we might decide we need to terminate this study, or the outcomes are going against what we were wishing for and in a deleterious manner. Or it can allow us to modify. Is it the sample size we need to modify, or is it the sample design, so that we are able to strengthen our study? Or finally, it can be used as an early declaration of success, which happened in this particular case, where once they analyzed, they actually saw that even without going all the way to the set size, the sample size that had been set aside, the evidence of effect or of treatment was overwhelming enough to now declare early success of the study. And I believe that's what happened. And I believe that's what informed WHO to actually agree for this drug to be in the market for treatment. So those are my references. I know it has been a very statistical class, and I tried my best not to bore you so much, but I hope at the end of it all, you've been able to learn, picked out a few words, and it has made you want to now sit down and really understand how do we critique papers, and what's the purpose, and how can I go about it. In that way, we will ensure that our practice is evidence-based. So over to you, Bao, and thank you so much for your attention.
Asante, Daktari. Thank you very much, Daktari, for the detailed and the well-researched presentation today. Thank you very much. I do appreciate your the efforts that you have done to ensure that today we are well presented to Daktari. Asante. So I'll take in the questions, Daktari, one by one. I requested our members to probably type the questions on the Q&A section. And I can see from the Q&A section I have no questions. Probably Dr. Farida, I can only allow you to type in a question at the Q&A section. I can see you've raised your hand, Dr. Farida Chakera. Kindly type in on the Q&A section and be able to respond there greatly. So there is, let me look on the chat box. There are some questions which are usually posted on the chat box. Okay, just 1 minute. Okay, the main question is on the CPD points for PSK, the person who deals with the CPD points. I'll write that on email. I'll write that on the chat box. That is Dr. Eric Muringu, operations@psk.or.ke. Okay, there's a question from Jackie Nkonge. Can you briefly explain how the species document, SPSS document works. Dr. Massey?
Thank you, Mbao, and thank you, Jackie, for your question. Just to note that SPSS is actually a software which you feed your data into, and the software then now, depending on the data and the parameters you've set, will analyze the data for you and give you results. So SPSS is one of those softwares that are acceptable widely or across a range of countries, a range of professional bodies. So basically it's a software. Once you input your data, set the parameters, it is set to give you the results. The good thing with it is that it has different analytical tests. And so it will be able to give you, it will help you to analyze your data in a way that I think as humans, you might not. Yes, I will also invite comments from other senior, professionals, anybody else who has comments. They're free.
There's a question from Dr. Farida Chakera. She asked, how do you check for the ethical parameters?
Thank you. Said Farida, right? Yes, thank you. That's a very important question, because in clinical studies, we are dealing with one human life. Even as we are assigning them placebos and intervention, there are ethical issues we need to address. So I think one of the ethical issues is to first get regulation from relevant bodies. So these are the institution regulatory boards that now allow you to conduct research. Before they allow you, they have to go through your protocol and see whether you've done your very best to minimize harm to the patients. So the first one is to get regulation from ethical bodies. Then the second one involves use of informed consent. As you're recruiting a participant for most trials, even before you introduce your study, you need to ask them whether you need to ask for their consent. Should we go ahead with this? So for me, I think under ethical issues, those are the key ones: regulation as well as the informed consent.
A quick one, Daktari, from our senior respected member, Dr. Anthony Kamau. In Black subpopulation, we see the subpopulation are not statistically significant. Does this mean that the drug may not be effective in our setup?
So allow me to share. We go back to that slide. Okay, there we can look at race. So the race were categorized as American, Indian, or Native American. Another subgroup was Asian, Black, or white. So we can look at Blacks. The Blacks that were that participated in the intervention arm were 157, while in the placebo arm were 142. So we can see the number of events. The incidences of hospitalization were 10 under the intervention arm, were 10 in the Blacks and 29 in the whites. But when you look at that, 10 over 157, whereas 29 over 556, it would appear that the Blacks, the effect on the Blacks was not as strong as the whites. However, before we look into that, we can now discuss other confounding factors, like the sample size. You can see between the white and the Blacks had 157 participants, while the whites were 556 participants. So that could be a confounding factor. So the study shows a skewness towards the whites, that the drug seems to be working better in whites. But I don't think we can quickly draw that conclusion, bearing in fact that the sample sizes of white versus black are significantly different. And therefore, before we nullify this result, especially for the Black population, we might need to do another study that's designed to, that designed specifically for Blacks, or rather the outcome is geared towards Black, so that we can now be able to say, yes, it is true that the intervention is not as significant in the Blacks than in the white. So for this, I would say we need to do more studies before we completely nullify that it's not as effective in Blacks than in whites.
Asante, Daktari. So a quick one also from so on that question by Dr. Anthony Kamau, it's now probably pertinent, Daktari, that from what COVID is explaining to us, do we now need to be even conducting our own clinical trials, and do we now need to even document them worldwide? That's because it is now well understood that out of the long duration the Black population has been out of Africa, those in America and all. There's a change in genetics due to the food and change of generations. What happens to now the Blacks in Kenya? What happens to the patient in Mogotio? Are we able to now even do clinical trials for our patients in Kenya? That is the first one. The second one is by Dr. Brian Nyangeri. Doc, by just looking at the forest plot, can we then make an inference as to whether a variable is a risk factor or it's protective? You can handle those two questions, Daktari.
Sorry, Mbao, I lost you a bit. The first question was?
Is it now time that we now move from just following up on clinical trials done in America and Europe, and now coming in documenting our own clinical trials, even for drugs to be approved in Kenya, that it has to have undergone clinical trials in Kenya and Africa as a whole, due to the change of genetics out of the Black population in America and the Black population in Kenya. It's a total whole change of genetics. A quick one on that.
Mm-hmm. You're right, Bao. I think very few studies have come out of Africa. Yet, we do know that even when COVID was especially in high gear, people thought that more people die in Africa. Then they were shocked that that was not the case from COVID. So there is a difference between populations. We may generalize studies because they've been conducted in a robust way. However, as you've rightfully put it, it is time now to do our own studies and see, for real, do these drugs actually have the same impact on our population as the study population? So yes, it's time to do our studies. And I think that will come in from if relevant bodies actually build capacity in Africa to do those studies.
Okay, Daktari. So the second question is on that question is by Dr. Brian Nyangeri. Doc, just by looking at the forest plot, can we then make an inference as to whether a variable is a risk factor or it's protective?
Thank you for that question. So we are asking whether if that variable is protective, come again, protective and?
Is a risk factor or it's protective? Whether a variable is a risk factor or it's protective.
Okay, all right. So the forest plot tells us if the difference we've seen is statistically significant. That means that the effect is largely due to the intervention, or the effect is enough to allow us to change our practice. I hope Dr. Kamau can confirm that. So I would say at face value, yes, we would quickly look and see that statistically we saw that it seems it was working better in females, in obese, in whites. But then you also have to look at other confounding factors before you now, make your judgment. So yes, at face value, yes, it may inform, but you need to go deeper and find out, are there other confounding factors like we've seen in the sample size of the blacks and the whites? We might say then that being white, you know, the drug is working better in whites than in blacks, but as we say, there could be other confounding factors. In that case, probably the sample size could have an effect or an impact on the differences we've seen. So at face value, probably, but then that will now bring in the issue of you doing more doing due diligence, finding out, are there other confounding factors? Are there other studies on the same? What did they find out? So it's just about more research.
Probably the last question now by Peter Cherut. Sorry, the assertion that the study must be done in our population for it to gain acceptance is not necessarily true. So it's just giving a comment. Probably how do we take it on that, Dr. from Peter Cherukich?
That is very true. I mean, we can't repeat. Remember, these studies take long. They are also capital intensive. And then there's also the aspect of external validity. So once you've ascertained that this study has internal validity, does it also have external validity? Because now external validity is generalization. Can we generalize the results to other populations? So if it does, then that, as he's rightfully put it, we can actually just adopt the study as our own. Where we might need to do more studies is when we feel that the research question wasn't geared to answering a question. How do I put it? It wasn't geared towards a general population, or rather you feel that the results were not robust enough to answer to the query you have about your population. So then that's when there is need for more studies, because some researchers actually elicit more studies. They answer, but then the answer is halfway there, so you still need to do more studies. But once a study has internal and external validity, then you're right, we don't need to do it. We can just generalize it to our population.
Okay, thank you very much, Dr. I'm much grateful for the time that you've been able to take us through the Q&A, Dr. I'm much appreciative. To our esteemed listeners for today, we much appreciate. Asanteni sana for joining us. With that, I'll ask and I'll request the chairperson KMA, the vice president KMA, to give his closing remarks on that. Dr. Amos Otara, are you able to give us the closing remarks?
Yeah, sorry, you lost me. Oh yeah, that was a wonderful presentation, Massey. I think you've done more justice than the topic that was presented. You've taken us very deeply into how to appraise articles and research on randomized controlled trials, and a number of things that I think most of the members who have participated here would have wanted to learn. There's been a lot of learning, all the way from how to write a paper and even how to analyze a paper. It's great. It was a pleasure hosting you all. As we said earlier, Kenya Medical Association is ready to work with all the other professionals in health to ensure the best practice of medicine, more so using the evidence-based practices. So these sessions, we usually have our sessions on our mental health session on Tuesday evenings from 7 onwards. And then we also have this particular clinical session that is held on Thursdays from 2 p.m. So it is a pleasure that we've learned a lot today. And I want to thank the presenter. I want to thank our host today for doing a splendid job. So until we meet next time, be safe. Thank you.
Asante sana, the Vice President, Kenya Medical Association. Without further much ado, ladies and gentlemen, I will request as Asante Daktari, we can now see you clearly.
Oh, sorry,
Oh,
Yeah,
you are at work, Daktari. Wonderful.
Yeah, I
Wonderful.
was at work, but
Daktari.
I've followed through it all. Thank you.
Asante, Daktari. So without further much ado, ladies and gentlemen, it has been my honor to take you through today's and to be the moderator for today's meeting. My name is Dr. Mbao Gitao. I am a pharmacist practicing at the Pharmaceutical Society of Kenya as a communications university. It has been an honor to host you all. Without further much ado, I wish you a great evening and a blessed week. We meet next week on Tuesday on the mental health, and next week on Thursday on the clinical, the case management practice. Sina budi ila kuaga na kuambia alamsiki.